So Dr. Millet is from Ochsner Health. He earned his medical degree from the University of Cincinnati. He performed his residency at George Washington and completed a fellowship in hematology and oncology at Emory. While at Emory, he received the ASCO Conquer Cancer Young Investigator Award for his excellent work in the field of immunotherapy in cancer. And this comes to no surprise to me or anybody else who's been in tumor board with Dr. Millet, who somehow managed to make a room full of smart people feel a little less smart. So he truly is a brilliant physician, and today we'll be discussing systemic therapy and resectable lung cancer with the growing role of targeted therapies, immunotherapy, pre and post-surgical setting. I do not envy this task. It is truly getting to be muddled water, so I'm sure he'll make it a little more clear for us. So everybody, welcome Dr. Millet.
All right. Good morning, everybody. Like Dr. Dozier said, with very kind and undeserved words, my name is Linwood Millet. I am a thoracic medical oncologist here in New Orleans at Ochsner. There's a little bit of a surgical bent this morning. As anyone who has ever watched me try to cut my food can tell you, I am the furthest thing from a surgeon. So we will be focusing on systemic therapy options in resectable non-small cell lung cancer. If I can make it progress. Okay, got it. I have no disclosures. So today we'll be talking about this rapidly changing landscape of systemic therapy options. I'll try to discuss optimal sequencing of systemic therapy and also discuss our future directions. This is going to be a very curvaceous presentation. I apologize in advance. We'll be flying through some of these slides. We'll be talking about a lot of phase 3s. It's not exhaustive. I won't be talking about the Chinese NeauxTORCH study or the more recently published neoadjuvant Ipi-Nivo paper. But I will be hitting what I think are most of the germane studies. Also want to make a quick note that some of these studies use the 7th edition of the AJCC staging criteria. Some use the 8th. Big difference is that in the 7th version, 4-centimeter disease was considered stage 1B, and the 8th and soon to be launched 9th editions, that is stage 2A disease. So most of these studies will be looking at a disease at least 4 centimeters in diameter or lymph node positive. So the ultimate aim of surgical treatment of non-small cell lung cancer is cure. We know that some proportion of patients will achieve this with surgery alone, but that rate decreases with increasing stage of disease. In order to improve the chance of cure, there are a number of strategies implementing systemic therapies in concert with surgical resection. These include adjuvant therapy given after surgery, neoadjuvant therapy given before surgery, and then perioperative systemic therapy given on either ends of surgery. In the beginning, there was chemotherapy. Actually, no, there was just surgery, and then there was postoperative radiation therapy. LungArt trial in 2021, I think, kind of knocked port off of the table, no benefit in stage 3A disease. But we did see in the early 2000s improvement with adjuvant chemotherapy. The first approvals were actually around 2003, but I'll be starting this timeline in 2008, which was the publication of the LACE meta-analysis, kind of what we based a lot of our recommendations off of. But in just the past 5 years, there have been a rapid series of approvals in the adjuvant, neoadjuvant, and perioperative regimens, color-coded for your viewing pleasure. This makes for a very crowded and confusing landscape. So in order to kind of better parse these data and build a framework for sequencing treatments, I'll first talk about adjuvant therapies, then neoadjuvant therapies, and then finally perioperative therapies in patients who do not harbor actionable genomic alterations, and then we'll talk about EGFR mutated and ALK-rearranged patients. So starting with the pre-immunotherapy era, let's discuss just adjuvant chemotherapy by itself. So again, goal of upfront surgery is to effectively remove all extant cancer. And it's in part for this reason that anatomic resections have proven superior to excisional approaches. That said, there is always a risk of residual microscopic disease, and the role of adjuvant therapy is to eliminate any of that with the ultimate goal of decreasing rates of recurrence. In the pre-immunotherapy era, the standard of care was to provide adjuvant platinum doublet chemotherapy in patients who had stage 1B disease, again here defined as 4 centimeters in size or greater, or patients with positive lymph nodes. This was based in part on the large LACE meta-analysis, which came out in 2008. It pooled the 5 largest trials of cisplatin-based chemotherapy in completely resected patients. As you can see, the absolute OS benefit at 5 years was only 5.4%, and the absolute disease-free survival benefit only 5.8% at the same time. If you look at the subgroup analysis, you can see that this is generally driven by higher stage disease, which makes use of adjuvant chemotherapy in the lower stage populations of less certain utility. You can actually see with stage 1A disease that, in fact, observation after surgery was clearly superior. Based on these data, guidelines did recommend using adjuvant chemotherapy in patients with at least 4 centimeters of disease or positive lymph nodes. Also could be considered in patients with high-risk features like lymphovascular invasion, neuroendocrine differentiation, visceral pleural invasion, et cetera. Also, there were some trials that showed neoadjuvant chemotherapy by itself had about the same outcomes as adjuvant. I think in practice, most people still reached for adjuvant, so we won't belabor that point. But fortunately, following the unprecedented successes of immunotherapy in the metastatic setting, it made its way into the locally advanced stage. As you can see, without exception, each of these large phase 3 clinical trials reported their data within the past 4 years. So starting with the adjuvant immunotherapy options, presently there are 2 regimens in widespread use. The first is use of adjuvant atezolizumab, approved in 2021 or published in 2021 based on the Empower-10 trial. So this evaluated patients with stage 1B to 3A disease, again 4 centimeters, it's the 7th edition here. After resection, patients were given 4 cycles of cisplatin-based adjuvant chemotherapy and were then randomized to receive either 1 year of atezo or best supportive care. Primary endpoint was disease-free survival and secondary endpoint was overall survival. So the top curve here is disease-free survival in patients with stage 2 to 3A disease with a TPS or PD-L1 tumor proportion score of at least 1%. You can see the 3-year disease-free survival is 60% in the atezo arm and 48% in the control arm with a pretty good hazard ratio of 0.66. Results were slightly less pronounced in the larger population consisting of all PD-L1 expressions, and you can see the numbers here. There are some important subgroups that we need to consider in this trial, perhaps chiefly the PD-L1 expression. As you can see, it appears that the majority of the benefit was derived in disease expressing a PD-L1 of at least 50%. And in fact, the lower PD-L1 expressions crosses 1. They cross the confidence interval at 1. It's also worth noting that EGFR and ALK-positive patients did not seem to benefit from the addition of immunotherapy. This mirrors what we know from metastatic trials. That said, these data are somewhat difficult to interpret. A lot of the patients did not require NGS, chiefly those with squamous cell histology. Not to be outdone, 1 short year later, Pearl's Keynote 91 published their data, and similar to this trial, it evaluated patients with stage 1B to 3A disease after surgery. Unlike Empower-10, enrolled patients were able to receive either cisplatin or carboplatin, or in fact, they were allowed to receive no adjuvant chemotherapy at all in advance of a year of pembrolizumab. There were dual primary endpoints, DFS in the overall population as well as in the PD-L1 high population, and a secondary endpoint of overall survival. The left curve here is the overall population with a 3-year DFS of 58% in the pembro arm versus 50% in the placebo arm. The right curve was the other primary endpoint, high PD-L1 expression. You can see that there is a trend towards improvement, but this arm notably failed to reach a statistically significant difference. The authors postulated an overperformance of the placebo group, but I think this is an important reminder that PD-L1, while helpful, is an imperfect biomarker for determining the efficacy of immunotherapy, potential efficacy of immunotherapy in a patient. So again, looking at some subgroups, it's important to note that patients who did not receive cytotoxic chemotherapy did not actually seem to benefit from the addition of pembrolizumab alone. We have to take this with a grain of salt. There are relatively few patients for whom this applied, and those patients were likely lower stage disease. We already know that patients with lower stage disease tend to derive less of a benefit from adjuvant therapies. Regarding PD-L1 expression, as shown in the previous slide, again, a TPS of 1 to 49% seemed to benefit the greatest. For disease with negative PD-L1 expression, there was a very strong trend towards improvement with pembro, but it wasn't quite statistically significant. Interestingly, here, patients with EGFR actually seem to improve, but again, we note the relatively low number of patients in this group, also reflected by the wide confidence interval. So summarizing these two trials, it's important to recognize that differences in study design and populations means that it's not appropriate to directly compare any two trials to one another. That said, when choosing between the two, I tend to consider atezolizumab for PD-L1 high expressors and pembrolizumab for low PD-L1 disease. Regarding the PD-L1 negative disease, if you look at NCCN guidelines, pembro for TPS of less than 1% is described as having unclear benefit. Personally, I think given a hazard ratio of 0.78 and an upper bounded confidence interval at 1.03, the results trended far enough to favor pembro to use in this scenario. In either case with pembro, I would use chemotherapy first based on the subgroup analysis we just looked at. Okay, now for neoadjuvant therapy. So I think it made a lot of sense to add adjuvant immunotherapy to the adjuvant chemotherapy we're already doing, but it's a bit more of a paradigm shift to move this up front in advance of surgery, recognizing this isn't something that we are really doing even with the chemotherapy alone. Generally speaking, the goal of upfront systemic therapy is to reduce the micrometastatic disease burden and improve chances of a complete resection, and in some cancers, to even downstage disease in advance of surgery. When we add immunotherapy to the neoadjuvant mix, there are actually a number of unique advantages as compared to adjuvant immunotherapy by itself. We have an intact pulmonary lymphatic system, which leads to increased T cell exposure to primary tumor antigens. We have exposure to a greater number of primary tumor antigens, which may allow for longer lasting anti-tumor effects post-surgery. And we also get to avoid endogenous post-surgical glucocorticoids, which can hamper T cell activation and proliferation. So the first approved regimen here was Checkmate 816, published in 2022. This study explored upfront chemotherapy plus minus nivolumab for 3 cycles, followed by surgical resection within 6 weeks of completion of treatment. Patients were eligible if they had 4-centimeter tumor or larger or lymph node positive disease. And the primary endpoints here were pathologic complete response and event-free survival, as well as secondary endpoints including major pathologic response, overall survival, and time to death or distant METs. You will note that these pathologic responses were not discussed, of course, in the adjuvant setting. So there was a clear advantage to event-free survival in the Nivo arm, with a 2-year EFS of 64% versus about 45% in the chemo-only arm. Looking at the subgroup analyses, perhaps unsurprisingly, we can see that the success of the regimen seems carried by higher stage disease and higher PD-L1 expression. Looking at EFS by stage on the left, stage 1B and 2 disease, you can see that there is not a statistically significant difference. On the right, with stage 3A disease, there's a much larger gap between the curves, resulting in a statistically significant superiority of neoadjuvant immunotherapy. And looking at by PD-L1, we see the same kind of picture. EFS by PD-L1 expression, there's definite benefit in higher PD-L1 expressors, and that perhaps scales the higher the PD-L1, the greater the EFS. Given this, we have to ask, is there benefit in using neoadjuvant chemoimmunotherapy in patients who have low-staged or negative PD-L1 disease? Well, if you'll recall, there was another primary endpoint, and it is perhaps the more exciting of the 2 endpoints that were explored. Almost 1 out of 4 patients on this trial had something called a pathologic complete response, meaning that at time of surgery, there was no evidence of viable tumor. Unlike event-free survival, neoadjuvant immunotherapy improved the chances of pathologic complete response in all stages explored and all PD-L1 expressions explored. There's also a significant increase in the number of major path responses, 37% versus about 9% in the chemo arm. And a major path response is defined as 10% or fewer viable tumor cells at time of surgery. This is noteworthy, as pathologic complete responses appear to be associated with improved outcomes. Looking at this exploratory analysis, the median EFS in patients who achieved a path CR was not reached, whereas it was 26 months in patients who received Nivo without a path CR, and about 18 months in patients who received chemo only without a path CR. We know that in other cancers, pathologic complete responses are associated with improved outcomes. In non-small cell lung cancer, this isn't as robustly demonstrated by prior data sets, but I think this is probably due more to the rarity of the achievement than anything in the pre-immunotherapy era. So extrapolating from other disease types, I think this is certainly a heartening result. Accepting that EFS is improved in at least some subgroups, and that pathologic complete responses are increased in almost all subgroups, the study led to the approval of neoadjuvant immunotherapy in all patients who had stage 4 disease, disease of 4 centimeters or greater, irrespective of PD-L1 status. Given this paradigm shift, I think it's important to consider the surgical implications of upfront immunotherapy. As I said, I am no surgeon. Dr. Pagdillon will be discussing this at length afterwards. I think some of the main concerns include toxicities from upfront chemotherapy and immunotherapy precluding patients making it to surgery, and also that immunotherapy itself will cause surgical complications or will cause the surgeries to be more challenging due to fibrosis from immunotherapy-induced inflammation at the site of cancers. If you actually compare the neoadjuvant chemo and immunotherapy arm versus the chemotherapy arm alone, you'll see that more patients made it to surgery, rates of minimally invasive techniques were increased in the combo arm, and rates of R0 resection were higher in the Nevo arm as well. So kind of summarizing the neoadjuvant portion, when thinking about what patients might benefit from this strategy, I think the question arises, should we apply this uniformly based on the FDA approval, or should we take into consideration PD-L1 expression and stages? Mechanistically speaking, it's more advantageous to expose a patient to immunotherapy while the tumor is intact. In my mind, I think that the chances for a pathologic complete response, irrespective of PD-L1 expression and stage, and also given that many of these patients would go on to receive adjuvant chemoimmunotherapy, I think it makes sense to offer this treatment to most patients who qualify based on this approval. That said, I know that there are others who are less inclined to do this, and it's definitely a conversation that we have to have on an individual basis with each patient. I think it's also important to recognize that any patient being evaluated for neoadjuvant chemoimmunotherapy must be discussed in a multidisciplinary manner first. We have to confirm the surgical appropriateness of patients before we pull the trigger on these drugs. In that vein, I also want to point out that this was not studied for downstaging cancer. The patients enrolled were those who were already good candidates for upfront surgery, so I would not use this regimen to downstage to surgery. Okay. Following the approvals of adjuvant and neoadjuvant immunotherapy came approvals for the perioperative immunotherapy setting. I think these studies sought to answer a very obvious question. If outcomes are improved with immunotherapy after surgery and before surgery, why not do both? Excusing this very colorful slide, we're going to discuss the 3 currently approved perioperative regimens. The designs are all very similar. They study a combination of platinum therapy plus immunotherapy, followed by surgery, followed by a year of immunotherapy, and they are all placebo-controlled. They really only differed from one another in the chemotherapy doublet offered up front, as well as the frequency of the immunotherapy given. In consideration of time, I will not be deep diving into the minutia of each of these. I will try to highlight what is most important. And notably, these all actually use the 8th edition. So this all starts with stage 2A disease, but it's the same population we've been discussing throughout. So in Keynote 671, EFS favored the Pembro arm, 2-year EFS of 63% versus 40%, and a median EFS not reached in the immunotherapy arm. Looking at the subgroups, yet again, higher stage disease benefited more than lower stage disease, though I will point out that here, stage 2 subgroup only missed the statistical significance by a hair. Upper limit of the confidence interval was 1.01. The effect does seem greatest in PD-L1 positive disease, though we do see a trend towards improvement in PD-L1 negative disease, similar to what we saw in 816. Surprisingly, patients with EGFR mutations seem to benefit here. Notably, the N is 14. I think there's a very wide confidence interval. It's difficult to interpret what this might mean. Most people, I think, tend to ignore it and do not offer this regimen for patients who have EGFR mutations. As with 816, there was a significant improvement both in major path response as well as complete path response. We also see that patients with a path CR have an improved event-free survival. Importantly, this study also demonstrates that in major pathologic responses, indicating that either of these response categories do increase outcomes or improve outcomes. The study also shows overall survival data, I believe the first of the 3 to do so. At the first interim analysis, it wasn't statistically significant, but the data are somewhat immature, and I think based on the curve, given time, this will solidify. Next trial is the Aegean trial. This one used durvalumab. Again, we see a significant improvement in EFS. Interestingly, well, again, no, not interestingly. It's more pronounced in the higher PD-L1 expression, though actually no subgroup here actually achieved statistical significance. This trial did allow for either cisplatin or carboplatin, whereas 671 only used cisplatin. There does seem to be a teeny advantage to carboplatin based on the confidence intervals, but there are a lot more patients who received carbo than cis, so take that as you will. As regards EGFR expression, these results are more in line with what standard thinking of immunotherapy in this population. Notably, the protocol was actually amended midway after the results of ADORA came out, which we'll talk about very shortly, to exclude patients with EGFR and ALK rearrangements. As with the other two studies, there was a significant increase in both major path responses and pathologic complete responses. Perhaps we are seeing a trend. Finally, we have Checkmate 77T. This used Nevo. Once again, we see improvement in the immunotherapy arm versus the chemotherapy arm. This time it's an 18-month EFS of 70% versus 50%. As with the other trials, stage 3 disease benefited more than stage 2 disease, and higher PD-L1 expression portended better outcomes, though all levels of expression trended in favor of perioperative immunotherapy. As with the GN, again, patients who received carboplatin seem to do better, though once again, the numbers are somewhat skewed. And again, we see a significant improvement in both major path response and path complete response in the perioperative immunotherapy arm. As before, patients with path complete responses appear to have improved outcomes compared to those who do not. Here you can see rates of definitive surgery, lobectomy, and RZO resections in the experimental arms compared to their respective control arms. In all cases, more patients made it to surgery, more patients received lobectomies, and there are more RZO resections excepting in the Nevo trial. The difference there is minute, and it is dissimilar from 816, which also used nivolumab. I think the only difference really is that 77T utilized an extra cycle of chemoimmunotherapy up front. So when are we going to use what? I've already made the case for using upfront immunotherapy. It allows, again, for improved priming of T cells against a larger number of neoantigens. There's access to an largely undisturbed lymphatic system, and we can avoid endogenous glucocorticoid release after surgery. But who benefits from the addition of immunotherapy after surgery if they've already received it upfront? As you can see in the cartoon, activated T cells persist following neoadjuvant immunotherapy and surgery. So how much more immunotherapy, if any, will benefit patients? Recognizing that immunotherapy is not a benign treatment and that ongoing receipt of immunotherapy can increase the risk of immune-related adverse events, we need to pin down what patients might benefit from postoperative immunotherapy. I think this is currently the question, and it is an unanswered one. Should patients with viable tumor receive more immunotherapy? Does the presence of viable tumor at surgery indicate relative refractoriness to immunotherapy? Should we use it in patients who did not clear circulating tumor DNA or who have minimal residual disease by some other test? Well, in 816, they did actually look at plasma circulating tumor DNA after resection. There was a greater percentage of patients with ctDNA clearance in the immunotherapy arm, and EFS does appear longer in patients who had ctDNA clearance as opposed to those who did not. This is also evaluated in GN. Patients with ctDNA clearance had longer event-free survivals regardless of PCR status. Based on these two studies, should we perhaps use circulating tumor DNA to aid our decisions regarding who does and doesn't need postoperative immunotherapy? To be clear, to my knowledge, there are no clinically available assays which are validated for this purpose, but I think this is certainly coming, so keep your eyes open. To sum up this very long-winded recounting of immunotherapy in resectable non-small cell lung cancer, I think it's clear immunotherapy improves outcomes. PD-L1 should be obtained in all patients, as this can aid in treatment planning. Personally, I prefer to use upfront immunotherapy for the previously discussed reasons. That means that I preserve adjuvant immunotherapy by itself for patients who are upstaged at time of surgery, perhaps who have a lymph node positive disease that was not found prior to surgery. That said, it doesn't mean that adjuvant immunotherapy is the wrong choice, as trials comparing the two directly haven't yet to report. Despite the number of perioperative immunotherapy regimens available, it remains unanswered who, if anybody, will benefit from the addition of post-surgical immunotherapy after having received pre-surgical immunotherapy. There are a number of ongoing studies attempting to answer that, but in the meantime, it's worth remembering that if you use Nevo up front, and you have concerning features afterwards, you can always kind of roll over to 77T and do another year of Nevo, maybe even using subcutaneous Nevo at that time. All right, these last two studies will be much more straightforward in their applications. So the first is the ADORA trial. It looked at the use of adjuvant osimertinib, which is a once-daily EGFR TKI, again in patients with a tumor of at least 4 centimeters in diameter or with lymph node involvement. The disease had to harbor an EGFR exon 19 deletion or an L858R mutation. Exon 20 insertions and atypicals were not allowed. Patients were allowed to either receive standard adjuvant chemotherapy or not, and then received ultimately 3 years of adjuvant osimertinib. The primary endpoint was DFS in the higher stage disease, and secondary endpoints included DFS in lower stage disease as well as overall survival. Now, these are the most impressive curves I have to show you. As with previous trials, the DFS appears greater in higher stage disease, hazard ratio of 0.1, which is very impressive. This is stage 2 to 3A. But even in the larger population, including 1B patients, again here 4 centimeters, there is a very impressive hazard ratio of 0.2. The benefit was also demonstrated in essentially all subgroups. Based on this initial analysis, it did seem that maybe there was some benefit to adjuvant chemotherapy, though again, it's important to recognize the disparity in sample size between those who received adjuvant chemo and those who did not. Since initial publication, there has been a 5-year update with pretty impressive overall survival data. Looking at both of these curves, you can see an early separation between osimertinib and the placebo arm, and that curve widens with time. 5-year OS in stage 2 to 3A disease was 85% versus 73%, and in the larger population, 88% versus 78%. Looking out at outcomes by disease stage, while there's only a statistically significant benefit in stage 3A, it is really close in 1B and 2. I think this is really helpful data. It does suggest a benefit of this pretty tolerable regimen in patients even with low stage disease. Also with 5-year survival data, they were able to somewhat better evaluate patients who did and did not receive adjuvant chemotherapy. Based on these numbers, there doesn't appear to be a significant difference between the populations, but remember that the study wasn't designed really to explore this. Prior to this, I had been advocating for the use of adjuvant chemotherapy in advance of osimertinib because we knew that there was some benefit, but I think with this, I'm inclined to forego that, especially in lower stage disease patients. And you can also see that median CNS disease-free survival was improved in the OC arm. EGFR mutated lung cancer has a predilection for the brain, so this is important data. I'm almost done, I promise. Moving on to ALK rearranged disease. This is the ALINA trial. This looks at the ALK-targeted TKI alectinib versus platinum doublet therapy in the adjuvant setting. Same population as before. All disease had to harbor an ALK rearrangement, and unlike with ADAURA, patients could not have received adjuvant chemotherapy. Primary endpoint was DFS, and secondary was OS. Top curve here shows stage 2 and 3A disease. Bottom curve, 1B to 3A disease. The 2-year disease-free survival in the intention to treat population was an impressive 93.6% versus 63.7%. That's a big difference. With time, I don't think it will be surprising to see overall survival data in favor of this regimen, as with OC. And also, as with osimertinib, we do see that there's a clear improvement in CNS disease-free survival with adjuvant alectinib. These early data suggest that adjuvant alectinib can prevent or even at least delay CNS recurrence. Considering just those 2 trials, as previously discussed, we know that immunotherapy is largely ineffective in patients with certain driver mutations, making upfront next-generation sequencing critical for all early-stage non-small cell lung cancer. I think a big and as yet unanswered question is whether we can generalize findings from ADAURA and ALINA to other driver mutations. There are presently ongoing studies looking at this, such as with KRAS G12C mutations, but right now there are no approvals in this space beyond EGFR mutations and ALK rearrangements. I do think it'll be interesting to see how these trials pan out, both in terms of results and duration of TKIs, especially recognizing that with LAURA, which is chemo rads followed by lifelong osimertinib, patients are on the pill in perpetuity. Here are my key takeaways. So most cases of recurrence after surgery are incurable with metastatic spread or poor prognosis. Improved disease-free survival and event-free survival represent a meaningful benefit to patients. NGS and PD-L1 should be obtained really on all non-small cell lung cancer patients. I would also consider concurrent liquid biopsy to increase sensitivity. Always discuss neoadjuvant therapies in a multidisciplinary manner before pulling that trigger. And here is a very easy to read table summarizing all of the data. All right, thank you.